if no question arises, I will.
I'll kick off because it's really important that we exchange ideas. So one of the ideas of the Better Health Programme that we're supporting is to create a connection between different countries so that we can learn from one another. And I think every country faces different challenges, but we all face some common challenges. So our common challenges are that we have aging populations, increasing health expenditure, we have the challenge of training and retaining sufficient health workers. But we all have different sort of community structures, different cultural contexts. And what struck me in, as I mentioned already at meetings yesterday, is how countries like Thailand and Mexico still have a very heavy reliance on communities to provide a lot of care. And it's whether that strong community will survive rapid urbanisation, shifting expectations, and can you protect the community and maintain its values given all of those other demographic, economic, social shifts? Because if you can't, then the costs of providing health and social care increase exponentially, and then services become unsustainable. And yet, the other session I mentioned yesterday is we do focus in many of these meetings on health care rather than on health. And we talk about sickness services really rather than health services. And we don't nearly spend enough on health promotion and health protection. So have we got the balance right? I would suggest we haven't. And can we protect, engage, empower communities more effectively? And how do we do that?
Like this morning, I have had discussion with our two colleagues from Canada and Sudan. So both of you to share your perspective based on your country context as well.
Well, I can start. Thank you for that. I mean, as the country that is notoriously known for declarations on health promotion, you cited one, Ottawa Charter. I would argue that we haven't done a very good job at implementing our own advice, because I think we also haven't gotten the balance right. On a good day, the services that are focused on prevention in the health system, and I'm not talking about the services outside of health, we're talking about public health, health promotion, probably on a good day 5-6% of the healthcare spend, and so that's completely off kilter, and that's despite lessons learned from SARS, which we're reliving again globally now, that led to the creation of public health infrastructure in the country. So I think we are having a hard time. I think part of it has to do with the fact that we do a lot of innovation and a lot of piloting. We don't actually go beyond the demonstration phase and actually scale up. So I think we know what the problems are, but we need to do a better job at scaling up some of those solutions. And I think we have some good examples in the area of tobacco control and a few other areas, but we could do better. So, I mean, I could go on, and I probably will in a couple of days on one of the panels that I'm supposed to be on, focused on that. So thanks for the opportunity to talk about that.
Thank you very much for your comment.
Thank you. Very nice to meet all of you here in this room. In Sudan, me I work in National Health Insurance Fund, HR General Director. We have changed our strategy from the provision of the service to purchase. National Health Insurance have own facilities, but now we are purchased as service from Ministry of Health and private sector. Sudan have 17 states in rural area. We face by the gap of the provisions. We have now in some areas we have health workers, some general practitioners, and in towns, the specialists and physicians. This is make health insurance have some complications with the satisfaction of the patient. And there is no service in the rural area. In the managerial issue, we have in the Sudan economic issue. All of qualification people want to go out for money. Here we need to, how we can invest, how we can make integration with the others. All of us are public sectors, health, Minister of Health, health insurance, but any one of them work alone. There is no integration. There is no unit. The policies are fragmented. Yesterday we talked about health finance. Why we can work together, health finance for all policies, for all topics, for investment in HR, investment in facilities, investment in health professions. We need to a policy to pooling the finance and how to reallocate it for the rural area and investment in the HR. Now health insurance covered, we have 40 million population, as health insurance covered 72 of the whole population.
I was wondering if I could ask a question, because community health workers have come up quite a bit. You know, they're called ASHAs in India. We have them serving rural and remote areas in Canada as well. They're called community health representatives. And while I think their integration into the delivery of UHC varies by country, and I think that's interesting, I guess one of the problems that I'm seeing, A, it's a very gendered phenomenon. Secondly, are we building UHC on the backs of poorly paid workers? Full disclosure, I do research on work and health, but when we think of labor as a major cost in all of our systems, how sustainable is that? And is there something fundamentally wrong if we're not providing them with the kind of support, the training, the infrastructure, similar to all the incentives that make doctors want to stay in rural communities? I think community health workers also deserve that, because they are actually doing a lot of work to help reach those in the last mile, the hardest to reach, and leave no one behind, to quote the SDGs. So I think that is a fundamental challenge for all countries that I just want to sort of put out on the table. Any comments from the panel on that? I know there's no easy answer, but it's just something that's been going through my mind as I've been hearing the excellent talks this morning.
So just a couple from me. One is on the evidence for the effectiveness of community health workers. I mean, I participate in a systematic review of community health workers and their effectiveness. They can be effective, but there are all sorts of conditions that do need to be attached to their effectiveness. And one of the areas where the quality of community health workers' work tends to fall down is the lack of ongoing supervision and support and continued investment in their training. So it may well be that community health workers, once they're trained, deliver good services for 1 or 2 years, but unless you continue to train them, unless you supervise them, the quality of their work will decline, and they will start to take on other functions for which they're not trained, and they become quacks rather than community health workers. So there are dangers. And we always fail in regulation, supervision, and support. And the other issue of payment also is critically important, because once people are given status, if you don't pay them properly, then they can start charging, and you suffer the same problem with under-the-counter payment for services as well. So community health workers might be part of the solution, but we shouldn't just see them as the solution in and of themselves. So they do need to be part of a system. And that's why I'm quite interested also in the level of community engagement, because we saw, I think in 2006, the World Development Report, which talked about the long and the short routes of accountability. So any health worker needs to be accountable. So they can either be accountable to their health system through supervision, or they can be accountable to the communities they serve. But the short route of accountability is accountability to the communities that you serve. But because generally in healthcare there is information asymmetry, so the population doesn't necessarily know what the health workers should be providing or how to judge their standards, then we do need to empower communities to better judge the quality of their health workers and to know when their standards are slipping or when they're not meeting expectations. So we come back to this very same question of how do we inform and educate our communities so that they, one, better manage their own healthcare, and then two, have realistic but high expectations of the people who serve them, and have mechanisms for complaining when the services aren't provided effectively. So it is actually an incredibly complex issue. So I'd hate to think that community health workers are a simple solution.
I'm Dr. Sunil Deandris, Additional Secretary Medical Services, the Ministry of Health, Sri Lanka. So I want to share some experience in Sri Lanka that introduce. So we have introduced a private healthcare project with the help of World Bank and the ADB. So accordingly, around 100 primary healthcare clusters will be formed in the country within the existing health system. There is an Apex hospital, which is the higher level secondary care and hospital, and the smaller, around 5 to 6 hospitals of a cluster, so that laboratory services and other resources will be shared. And there will be minimum standards of each and Apex hospital and the cluster hospital. And not only that, so that ensuring of a drug and other facilities will be ensured with the standards norms. And also, as you correctly mentioned, that how to mobilize communities, we have introduced a kind of hospital, the health-friendly society around that Apex hospital and the cluster hospital. It's an official kind of government policy that the government administrative agent in that particular area will support, and the government agencies will nominate, and also the volunteer organization will be representing that. So they were given tasks and the scope of work, so that how they will interact in future pertaining to the health of that people in that particular area. That's one. And secondly, we have introduced a grievances handling system of that area, online system and paper-based system, so that anyone can give their feedback to the health ministry, line ministry, so there is a mechanism so that we will receive the grievances from the people of that area, so that they can enter into the website and give their, or otherwise simply writing, those people who cannot do it. Another one is that modular training for the medical officers in that Apex hospital and base the first hospital in 6 major aspects, that is that infection prevention, the NCD prevention, and likewise modular training online, so that they will be in a standard kind of format, standard, so that they will be handling the things in a similar way, uniformly to maintain. And also, we have, in order to ensure that the health workers are employed equally distributed, so we have introduced, that is practicing for quite a long time, that is merit based, so that those who are passing out from the advanced level, they recruited according to something called formula, Z-core. Z-core, that is a very complex formula that is given weightage to the difficulties of that area and the district quota and so on. So that each district will have their own someone in the institution for the training to ensure. So it is to ensure that somebody is after training going to that particular area. And according to the merit code of the final exam, the training school will be distributed so that the first one has a chance to apply for any place of the vacant places out of. The last one of the list should go what we assigned, so that he has no choice, that he has to go. There is kind of a system, but we have difficulties. There are some kind of professions like public health midwives. It was the glamour of the Sri Lankan health system to have the very good MCH care. We got very good in the standards in the MCH care comparably. But problem is that now the young girls are not coming to that particular profession. So they have to walk around and go to the houses and all. So there are ample opportunities, educational opportunities like good old days. So therefore, we are trying to having some flexibility over the recruitment criteria. Sometimes something to do is happening to nurses also to some extent, but there are certain categories. But we have introduced some incentives in the sense not financial, but change the uniform to hand some kind of uniform for the girls and the moped so that they can walk around, mobility to ensure. So there are some things to be introduced to ensure that the vacancies to be filled in future. So these are things happening in Sri Lanka at the moment, particularly to the primary health care and the human resource development. Thank you.
Thank you very much. We will have about 2 questions left.
I just want to come back to the issue of community health workers and maybe echo a little bit what Neil was saying. I think what the evidence is showing is that if community health workers systems that put community health workers in the field are going to work, community health workers have to be properly paid, they have to be properly supervised, they have to be properly trained, supplied, monitored, all of these things. And the challenge is that actually requires a system. You need a system for a system. Again, based on my experience in Africa, community health workers seem like a great idea, and intuitively it really makes sense. But one of the big challenges is if you want to put 20,000 or 5,000 community health workers in the field, how do you pay them? How do you make sure they get remunerated? There's no banking systems. There's no electronic transfers. There's people don't have access to cash. I mean, are you going to add them as a cater to your health system? Are they going to be officially employed by the government? Are they going to be officially part of the health workforce? What's their status? I mean, these are questions that they're so challenging, and the challenges are so difficult to overcome that often it just is a massive impediment to making it work. I think that countries are exploring non-financial remuneration of community health workers, other ways to reward community health workers for the work they're doing. But again, if you're going to even do something as simple as paying them for their work, the systems that you have to have set up to do that are actually quite complex. So this is a huge barrier. It's not something that's particularly easy. And again, it's systems for systems. If you're going to build a strong health workforce, you need systems in place to start to do that. It's very difficult to do it from scratch.
I respond to the issue of gender. From my experience running the Faculty of Public Health, we found that the past 5-6 years, there are more female than male in some classes. 100% are female. So I think from my experience in Thailand, the gender difference may not big issue. As you can see, the leader of this platform is Professor Vanisha, is female. And as you can count, 4 of us, 7 of us here, 4 are female, 3 only male. So to my experience, probably gender is not a big issue for rural area in Thailand at this moment, because there are more female coming to contribute in the system. Secondly, for the issues of community health worker, how can we retain them? As Dr. Daniel said, I think it is quite complex issue, and there needs a long-term strategy, and also not just only one strategy. There needs a multi-strategy to attack this. For example, the case that I show you, yes, financial is important, but it's not much or less. It's about fairness. If they think the system can provide a fair financial to them, they stay, but it's not enough. I think you agree that continuing education is important for them, so that they can show to their community that they are competent and they are valued to serve their people, because they keep their continuing education, they keep their competency. And thirdly, I think family issue is important. That's why we did the local recruitment, because we hope that when they go back home, at least the family time will, sustain them in the local area. But it's not enough. Another one is social recognition. Social recognition that the society in the rural area accept it, and and if they say that, oh, we cannot like you, please stay longer. And we have many cases. For example, the last photo that I show you, that Hugh Thai graduate. Actually, he can go to work in the city area, which higher salary. But because the society accepts them, he was placed in the media with the the Royal Highness Princess. So when we asked him, why don't you move to the other area? He said, no, I commit with my princess, so I will live here. This is probably, I don't know if I answered your question, but I would like to show this case to you. Thank you.
I have 2 points to share with you. I echo Dr. Prodit for gender balance, because we have the rule for speakers to have to balance for the women and men speakers right now. And also not only gender balance, but generation balance as well.
I can ask what generation.
Oh, okay. So what's your generation?
FTC.
And for competency or quality of health workforce, for well-equipped health workforce, we have the accreditation system for health profession. Right now, we have 9 professions in our country. For physician, we have the accreditation system nationally and also internationally. But for other 8 professions, we have national accreditation system for those remaining 8 professions. But we're going to move to international health accreditation system. That's for the students, for graduate. And right now we're going to move to CPD. We work with Better Health Program with NHS and HEE for those kind of qualification. And right now I am one of a technical working group from World Health Organization. We just have the meeting last 2 years ago and also last 2 months on framework of competency of community health workers. And right now it's under the review and gonna launch, I think, in a couple months on those competency for community health workers that will fit for universal health coverage. I can share with you later on.
I just had one comment on, because I think that the point from Sri Lanka on gender was also about gender-based violence, though. So, and that's an important point not to lose. So in 2002, I think there was a report in Bangladesh on why nurses don't nurse, and a lot of that was because night nurses in particular were being attacked, raped, assaulted, and therefore locked themselves in their nursing stations, and a lot of the nursing care was delivered by dressers, male dressers who were working at night. So we've had over 20 polio workers, female workers in Pakistan killed for giving immunisations. So again, there's a gender impact. So security of staff working in hospitals and working in communities is particularly important. So I think that was partly the point. We do need to ensure that we have a duty of care for our health workers. And we are seeing actually in casualty departments in the UK increasing violence generally against health staff, people drunk or coming into healthcare facilities attacking staff. So there are other things that we need to do if we want to protect health workers. And you may not have experienced these problems yet in Thailand, but they're not unique to the UK or to Bangladesh or Pakistan. There are many countries in the world facing some of these challenges. So part of incentivising and retaining health workers does mean to making sure that they work in a safe environment.
So thank you very much for all the constructive comments and interesting questions and many creative solutions on the healthcare workforce. And today it has been like a meaningful presentation, discussion, and also resolution. But right now we have reached the last part of our meeting, which is a summary by the speakers. Each speaker have 3 to 5 minutes to deliver the take-home message and a very short, remarkable summary. So please.
Well, I think it's been a fascinating session, lots of important points. Clearly, Dr. Suet summarised very well in his comments. I mean, the health workforce is critically important. We do need to invest in them. Yes, community health workers are incredibly important, but we need to ensure that they're appropriately trained, supervised, and they fit within an effective system. There's a huge amount of variation globally in how we structure our health services, but we do need to learn from one another. And certainly we in the UK would very much appreciate learning from the innovative solutions that are being developed in many other parts of the world. And frugal innovation, doing more with limited resources, will become increasingly important for all of us. And so the more we can share information through global platforms and through meetings, but hopefully increasingly digital meetings, because we can't all afford, carbon-wise and climate-wise, to travel the world in order to have these discussions. We need to find other ways of communicating effectively in order to build that collective knowledge. So those would be my final comments.
Thanks. First of all, I want to thank Juanita so much for inviting me here. I'm not a boomer, by the way. I think I'm whatever comes after boomers. But I just really, I'm struck by the complexity of this issue. On one hand, we're talking about digital innovation, etc., and on the other hand, so many of the world's healthcare workers are working in situations like in the slide that Aiga showed in Burundi. I mean, there's such a spectrum here. The WHO has a global strategy for universal health, 2030. There are probably 50, it's one of these WHO documents, there's 64 pages. There's a policy recommendation for almost everything that you can imagine, and I think countries should pick and choose. I actually have 3 very concrete recommendations based on, again, on my own experience. And that is that really every country needs to have a group, a commission, or a group of thinkers on on health workforce, on human resources for health. You can't just have one person working in a corner office in a ministry. You need to have a group of thinkers on this to push forward an agenda across successive administrations. I think that's what Thailand did very successfully. Many ministers have a short vision because they know that their terms are only going to last 6 months to a year, so they don't play the long game, which is what you need to do when you're talking about health workforce. So you need to have a group of people, of champions, of thinkers who can develop policy and push that over successive administrations. I think the second thing that you need to do is every country should have some sort of investment case for investing in health workforce based on locally generated evidence that they can use that to make the case that investing in health workforce not only improves health outcomes, but is good for economies in general. And they need to have a convincing argument based on evidence that they can use to advocate at all levels of government. I think the third thing is plans. You need to have plans, but I'm not sure how useful it is to have a 5-year plan for human resources for health in many countries. You need to, again, it's a long game in my opinion. It's a 15 to 20 year game, and you need to take short bites, set short, reasonable objectives that you can accomplish over a year, 2 years, and then build on those. Every country's starting from a different point, so you need to have reasonable, achievable plans to allow you to move forward. So those would be my 3 recommendations. Thanks.
So for me, I have 2 points. One, for health workforce, right now in our country, we start working together for all professions. Previously, we work in the community, and they can work collectively and cooperatively work by chance. But right now, we start with the education, interprofessional education, so they can learn together and they can learn each other what they want, what their role, and this will reduce the conflicts of their professionalism. So this is the one key point that we work on our health workforce development. For the second part, we work on resource optimization. As Dr. Sumi said, we still need dollar, but we will rely on our self investment, and also those resource optimization that come from the community. So we have the constitute to ensure the primary health care in the community. So people-centered and patient-centered care is our guideline. For resource optimization that I shown you for private sector to be partnership, only one question that I would like to leave for this session is how to close the gap of high healthcare demand and lack of adequate investment in equipped future health workforce. Thank you.
Thank you. First of all, I'd like to thank Professor Manisha to invite me to join this session, which is very good. I don't have any recommendation, but I have 3 points. I'd like you to help me to think about this when you have lunch. Firstly, in terms of education perspective, I think it is important to think about how to make a better training of health professionals for that they can work well in the team-based health services. How to make them not feel like inferior to the other health professionals. And how we do the skill transformation from one health professional to another health professional, and we still let them think about, yes, we work as a team. We don't be used. They are not used by the other health professionals. And this is an important issue. The second one is about multi-sectoral action that from the presentation that I show you, actually it's just one part of multi-sectoral action. How can we encourage private sector, not just only feel that they donate their money, but how to make them know their role, that they can do the better role, not just only money. Yes, money is important, but not the most important. Their role to encourage the other in the society to contribute to the health system. Last but not least, I think all strategy that Dr. Sumit informed us is all in the planning. As you can see, the HRS plan, the global plan for the 2030, I think all strategy are addressed. But I would like to use the word that I saw from the video clip in the primary health care 2018. We must act now. Thank you.
Just a special thank you to Professor Wanisha again for really allowing youth voice to be represented on this panel. I think it's really humbling for us to represent youth on such an important issue, and it's just really encouraging to see that when we're talking about investing in healthcare professionals, what the youth perspective is really does matter. So a very special thank you to that. My key takeaway really is kind of echoing what Dr. Daniel and Dr. Squire, as well as a colleague from the floor, mentioned about how there is a need of scaling up interventions. There's a need for investment cases. That basically there's no silver bullet for anything. Even for digital health, it is not a silver bullet. Even when we talk about implementing innovations, they need to be contextual, and they need to be addressing each of the issues faced in different communities. And I think there are a lot of different challenges that are often overlooked administratively, as well as just logistically. And there is a lot of opportunities for us to address those problems, but there's also an importance of us recognizing that there's no silver bullet to anything. And I think it's also really just, although it's a reflection, it's also very encouraging to think that, well, conversations like this do matter, because when we learn from country experience, community experience, that's when we find out what interventions really work. So just really encouraged by this panel that conversations like this need to continue. And when we look at more interventions to be implemented in different communities, it's also time to look at how similar these communities are and how we can best learn from each other's experience, so that each community isn't really just trying to pull out all the resources, finding a unique innovation to itself, but also just learn from each other, so that innovations that work from a community A with similar parameters with community B will actually work. And I think that should be one of the focus areas in the next 5 to 10 years when we look at scaling up innovations and different contextual interventions in communities.
So I would like to thank you, Professor Vanisha, as well, for giving an opportunity for Gen Zs like me to voice up my opinions, and also my peers for supporting me with information and also mentally. And, I would like to say that community health workers and doctors recruited from rural areas would be the solution, possible solution to the retention of doctors in rural areas. And I think we have to equip them with transferable skills, which includes both holistic care and empathy, and also digital knowledge, because AI technology is coming, and we need to be doctors who can provide them humanistic care. Also, people working in these areas need fairness for sustainability. Once they realize that they are doing much more than they are paid for, they will eventually think that it's not good anymore to stay in the rural areas and may move to the cities. And so I would like to say that students from super programs won't necessarily stay in rural areas anymore, I think. Because judging from people in my class, supers are students from very, very rural areas, but they are students who come into the cities to receive education, but their hometown is in the rural area. So they may move to the cities eventually, and that may be a problem to look into the future. Thank you.
Alright, ladies and gentlemen, finally we have come to the end of the morning session. We would like to say thank again to all speakers for their informative and interesting presentation. And that is all for this morning. Have a great afternoon and see you again next year. Thank you everyone.
Comment some words. So health workforce is very important, though we have artificial intelligence or robot, but they cannot replace health workforce. I think I thank for all speakers and also participants of our staff here, but we have to keep talking about health workforce issue for the remaining of the conference. Don't stop it. Thank you so much.